Hi, my name is Colin Rock. I'm the head of partnership development here at Black Health Matters. And I wanted to introduce you to an important health professional who will be discussing kidney disease. There's a gene called APOL1, and it's one of 6 members of the APOL gene family. Genetic variants in the APOL1 gene found only in individuals of recent African ancestry greatly increase the risk of multiple types of kidney disease for people of African descent. We're going to spend time and learn more about genetic kidney disease and have more insight into the APOL1 gene. Dr. Ogo Egbuna is a physician scientist with nearly 2 decades of clinical, academic, and drug development experience. Originally from West Africa, he completed medical school at the University of Nigeria before emigrating to the United States, where he completed his residency in internal medicine at Mount Sinai, followed by clinical fellowships in nephrology and kidney transplant medicine at the University of Rochester and Beth Israel Deaconess Medical Center, respectively. Dr. Egbuna completed a master's in clinical investigation from Harvard MIT School of Health Sciences and Technology, where he also taught residents, cared for patients, and conducted research funded by the National Institutes of Health. Currently, Dr. Egbuna is the Vice President, Clinical Development, and also the Global Clinical Development Lead for Vertex Pharmaceuticals APOL1 mediated FSGS program, which aims to develop a potentially curative treatment for the underlying cause of APOL1 mediated kidney disease. In addition to his role at Vertex and his professorship, Dr. Egbuna also offers pro bono advice to the leadership of Kidney Solutions, a kidney disease and dialysis center in Lagos, Nigeria. Thanks again to Vertex Pharmaceuticals for supporting Dr. Egbuna's presentation to our summit participants today. Dr. Egbuna, thank you very much for sharing your knowledge and information with our participants today.
Good morning, Colin, and everyone on Black Health Matters. As mentioned, my name is Ogo Egbuna, and I'm a nephrologist, and I've been taking care of patients with kidney disease for many years. Many, many thanks to Black Health Matters for the opportunity to present one of many kidney diseases, but of particular interest to people of African ancestry. Vertex is really excited to be able to support Black Health Matters in this spring's 2022 summit. A few words about Vertex is that we're a global biotechnology company, and we are focused on conducting fundamental research that gets to the heart or core causes of important and severe diseases such as cystic fibrosis, sickle cell, and in this particular case, APOL1 mediated kidney disease. And today I'll be sharing a little bit about one of many genetic kidney diseases, but an important one for the Black and minority community. All right, so why is this important? And especially for kidney disease. And I think if you start looking at the figure to the left, you'll see that there is a big disparity by race in the burden of kidney disease. And this has been something that is not recent. Actually, as early as the late 1800s, there were known disparities in the presentation of kidney diseases in minorities. And that, with more recent record keeping through the United States renal dialysis system reports, you can see here over the last nearly 20 years, there's been a pretty clear difference in the prevalence or occurrence of kidney disease in those that are identified as Black or African American, illustrated in the red line, compared to other races. And the reason why this is really important is because as the severity of kidney disease goes up, from mild to moderate disease to severe and end-stage kidney disease, the costs also go up. And that's what you see on the figure to the right. You know, from mild stages of kidney disease, you see out-of-pocket and other medical costs going up, all the way to advanced end-stage kidney disease, where tens, if not hundreds of thousands are spent on the individual by the individual patient and by the health system every year. And what are the reasons for this disparity? Well, we do know that there are socioeconomic factors, access to care, but we do know, just based on science that has emerged in the last decade or so, that some of this has a biologic or genetic basis. And that's what the story about the APOL1 gene is actually all about. Now, everyone, regardless of your race, has the APOL1 gene. But why is it particularly relevant in those of African ancestry? Well, to the right, you can see a figure that shows a global map that shows where people of African ancestry are found, certainly in sub-Saharan Africa, but elsewhere around the world because of course, modern day migration and the slave trade that predated that. But the APOL1 gene is important because it evolved as a way to protect people that lived in endemic regions in sub-Saharan Africa from a particular parasite infection. So that evolutionary advantage that provided protection against the parasitic infection called the trypanosome parasite is, however, the basis for what appears to be a survival disadvantage in terms of the risk for kidney disease. Now, people have, migrated, moved across the world in the last several hundred years, and that's why you can see that regardless of where you go, patients that identify as Black or have recent African ancestry actually have a rather consistent higher risk of kidney disease. And here you can see in the figure to the left, a map of Africa and the distribution of variations in the APOL1 gene. Like I said, everyone has APOL1 gene, regardless of your race. But in those of recent African ancestry, there are variations in this gene that have helped to protect against very resistant forms of the trypanosome parasite. So everyone essentially can survive, fight an infection with the parasite illustrated in the figure to the right at the top of the box, Trypanosoma brucei. But over time, this parasite evolved to become even more resistant, creating certain species called Trypanosoma brucei gambiense and Trypanosoma brucei rhodensiense, both the West African and East African sleeping sickness. So we humans that lived in such areas where these parasites are really endemic and prevalent developed variations in the APOL1 gene so that we could also fight these resistant forms of parasites. So again, the survival advantage has helped people that live in these endemic areas to overcome infections with this parasite. What happens is that the APOL1 gene expresses a protein, and then when those that are infected with the parasite engulf the APOL1 protein, the protein kills the parasite. So again, the APOL1 genetic variants associated with a survival advantage, especially for those that live in endemic regions, but is associated with not only an increased risk of kidney disease, but when you get kidney disease, you have a really rapidly progressive course. Now, not everyone of African ancestry has APOL1 genetic variants. About close to half of people just have what we call wild type APOL1. about 42% of people that identify as African American have just one variant, while about 13% have two variants. But for those that have two variants in particular, they have not only an increased risk of kidney disease, but a very rapidly progressive course. And it's believed that a very substantial proportion of patients that identify as African American have kidney disease due to possessing two variants of the APOL1 gene. Now, I just want to clarify that the APOL1 gene and its association with kidney disease is a relatively recent observation within the last just a little over a decade ago. And there are many other forms of genetic kidney disease. For example, polycystic kidney disease is actually even more common than APOL1 genetic kidney disease. But APOL1 driven kidney disease is particularly aggressive. And you can see here, these are just two forms or presentations of kidney disease that patients could have, one being what we call focal segmental glomerulosclerosis, and the other being hypertension-associated kidney disease. And if you start with the figure to the left, you can see the dark purple line showing the survival curves of patients with this disease compared to those that do not have these variants in the APOL1 gene. And whether you have what we call FSGS or hypertension-associated kidney disease, you certainly have a 2 to 3 times faster decline in kidney function, progressing to kidney failure if you have two variants of the APOL1 gene compared to those that have only one or no variant of the APOL1 gene. So how does variation in the APOL1 gene cause kidney disease? As I mentioned a few moments ago, the way the APOL1 gene and the protein that it expresses kills the parasite is that it punches holes in some of the systems inside the parasite. Now, the APOL1 gene is expressed in many tissues in the body, including the kidney. As I mentioned, not everyone has APOL1 genetic variants, even if they are of African ancestry. And not everyone with two APOL1 variants actually has kidney disease. But under certain circumstances, like infections or inflammatory triggers, what we call a second hit, the body sort of feels or thinks that it's under attack by the trypanosome parasite and starts increasing its expression in the kidney. And by increased expression in the kidney, it does very much the same thing it would have done to a parasite, which is punching holes in the cells of the kidney and causing kidney damage. And these now cause an interruption in the filtration mechanisms that the kidney is very important for. In terms of presentations of APOL1 mediated kidney disease, patients with two APOL1 variants and FSGS, hypertension, associated kidney disease, lupus, HIV-associated kidney disease, and actually many others, when they do have these APOL1 variants, it changes the course of these common presentations of kidney disease. There are patients, of course, of other races that could have these very same diseases, but in patients of African ancestry with these two APOL1 variants, the very same disease has a very different and rapidly progressive course. Well, how does APOL1 mediated kidney disease present itself? Well, there is no particular sign or symptom that says this is APOL1 driven. And in fact, many kidney diseases progress very slowly, and it's only when it's very advanced that patients begin to have signs or symptoms like fatigue, swelling in the legs, weight gain due to extra body fluids accumulating, or dark or foamy urine. And regardless of the cause of kidney disease, which of course in some instances can be related to the APOL1 gene and its variants, it's there, unless you have testing, you won't really know that you have kidney disease until it's very advanced, and then you start having these signs and symptoms. And this is why many may have heard about the need to get screened for kidney disease, especially if you have a history of hypertension or diabetes, or especially if you have a family history of kidney disease. Well, how do you identify if you have kidney disease in general or APOL1 mediated kidney disease in particular? Well, like I mentioned, the signs and symptoms are not specific. Many kidney diseases have very much the same signs and symptoms that I mentioned on the previous slide. But specifically, there are simple tests that can be done if you get a checkup with your clinician. A blood test that could be used to measure the filtration capacity of the kidney, a urine test to check for proteinuria, and this blood and urine test can essentially identify if anyone has kidney disease, but specifically to find out if it might be related to any genetic variant, and in particular APOL1 variants, in this case, genotyping. In some cases, your doctor may recommend a biopsy, which is a procedure where they take a needle, they stick it in usually through the back, take a piece of kidney tissue, look at it under the microscope, and try to identify what the cause of kidney disease is. So in conclusion, there are many causes of kidney disease, as I had mentioned, and we think that the high burden of kidney disease in people of African ancestry, to a large extent, can be explained by variations in the APOL1 gene, and that this variation in the APOL1 gene is emerged as a survival advantage to parasitic infections, but as a survival disadvantage in terms of risk for kidney disease. As I mentioned, early to middle stages of kidney disease may not have signs or symptoms, but simple tests that you can get at your doctor's office may help identify early evidence of kidney disease, especially if you're identified as, if you have risk for kidney disease, such as having a history of hypertension, diabetes, or a family history of kidney disease. Genetic testing can help identify genetic causes. And as I mentioned, there are several genetic causes of kidney disease. And in particular, for those of African ancestry, if this might be driven by variations in the APOL1 gene. And as I mentioned, knowing your family history and personal risks for kidney disease would be very important in order to take proactive steps on what to do to minimize your risk of progression for disease, to end-stage kidney disease. So with this, I'll stop, and maybe we'll take some questions from the audience. Colin, is that what we do next?
Yes, so I've put some questions in the chat there for you that folks have been asking.
Okay. So let me just come off share for a moment, and then I'll start taking some of those questions. All right, so here, one question is, there are nutritional and lifestyle approaches. Are there nutritional and lifestyle approaches by pharmaceutical companies to prevent kidney disease? And have there been any studies conducted by companies that have observed links between diet and disease? Well, the answer to this question is yes. Diabetes is one of the most prevalent causes of kidney disease. it's not always due to, I guess, poor diet and lifestyle. There's some people with diabetes